We're going to start out with osteomyelitis, which is on page 601 of your textbook. So, what is osteomyelitis? It's really an infection of bone, but it's an infection that causes inflammation. So it's the MYEL means the marrow of the bone. So this is inflammation within the bone marrow, and it's caused by any infectious agent. 99% of the time, it's Staph aureus or some other bacteria, but it can be fungal, it can be viral, uh, that kind of thing. It can be parasites for that matter. We generally classify it as either acute or chronic. And really, the acute osteomyelitis is a new infection in the bone, and then with inflammation. And the chronic is when the infection ends up being persistent and causes histological change within the bone. So it if it's left undiagnosed and untreated, then any acute can become chronic. So where does this come from? These infections can come either from outside through some sort of an inoculation. Generally speaking, it's a puncture sort of a wound, or it can come from the blood. The infection starts from the blood, ends up in the capillaries of the bone, and then takes residence there and causes the thing. So generally, it's small little puncture wounds that cause it if it comes from outside. So I had a patient who ended up, she was deadheading roses and ended up getting a thorn from the rose into the end of her distal phalange on her on one of her fingers. I think it was the third finger, if I remember correctly, and ended up with an osteomyelitis, and it was a raging infection and necrosis of that bone, and she ended up having to have the tip of that finger amputated. Another time that I saw this, and it sticks out in my mind. There was a vet that was taking care of my cat many years ago here in Barrie, and I spoke to her many times, and I talked, and I saw her lots of times. And one time, I was actually thanking her for putting my cat down, and I shook hands with her, and her hand felt funny when I shook hands with her, and she noticed my reaction and held up her hand, and she was missing, like she only had 3 fingers and a thumb. The little finger was missing all the way to her wrist, right to the carpal bones. So she was missing a metacarpal in her right hand. And she told me that what was happening was that what happened was she was doing surgery on a cat, and the cat came out of the anesthetic, turned and bit her, and the tooth punctured the metacarpal, and she ended up with an osteomyelitis in there and had to have that amputated and everything distal to that point amputated. So that would be an example of an inoculation from outside rather than bloodborne. So we look at factors about this. Like I say, it's normally Staph aureus, but can be Streptococcus, Pneumococcus, Pseudomonas, E. coli, Salmonella, all kinds of things. uh, you know, so the factors in the development are what's going on, uh, the bacteria that's involved, and how virulent is it, you know, how strong is it, uh, what's the person's health. Like, there's a lot of people prick their fingers with a rose or get bit by a cat and they don't end up with osteomyelitis. So what's the immune status of the person that's involved? What's their general health and their ability to fight infection? What bone is it that actually gets that? Like, there are some bones that have got lots of collateral circulation, and other bones where it's rather limited. And these all factor into it. So what ends up happening here is really kind of a complex thing. But ultimately, the bacteria gets deep into the spongy bone and into the bone marrow, and takes up residence there, and ends up forming an abscess, not unlike a tooth abscess. Uh, and uh, and there turns out to be a little bit of necrosis. Now, in the chronic forms, what happens is that there's a necrosis of the bone, and that bone dies. It's an avascular necrosis because of the infection affecting the vascularization, and we call that bit of dead bone the sequestrum. Now, the periosteum, the osteoblasts in the periosteum start laying down new bone over top of that space, and kind of envelop this dead bone, and that's called an involucrum. So this slide here actually shows some pictures, and what you can see is, like in that first picture, on the fibula, you can see there's an infection, and there's the little bit of dead bone. You can see it in two parts right in here, and then there's an overlay of new living bone right under the periosteum, enveloping it. So the sequestrum are those two little radiodense pieces, and the involucrum is the new bone that's laying over the top. In the one with the metacarpal, the index fingers, or the second metacarpal here, you can see that there's quite a bit of necrosis in the middle, and there's new bone forming on either side of that, trying to heal it. So the drawing is really about the inflammation and the infection and the abscess, and how it forms. You can just start to see that abscess is lifting the periosteum, and that's where the osteoblasts are going to lay down new bone, and create this involucrum. So this is an infection. Now, deep in the bone, until the periosteum is involved, there's not pain, because cancellous bone, spongy bone that is, doesn't have pain receptors, so you won't feel pain until the abscess starts to actually stretch and push on the periosteum, where there are sensors. It's an infection, so you'll get systemic things, fever being the most common. Now, if this is around any sort of foramen that is involved with nerves, or if it's in the spinal cord, or in the spine, and it starts to impinge on the spinal cord, you will get neurological symptoms. Um, and oftentimes that's what drives people to seek medical help, or the neurological symptoms, and the osteomyelitis is found later. Um, Sometimes they're just found on X-ray findings. Now, a common place to get an osteomyelitis, a chronic osteomyelitis, is at an open reduction of a fracture. So sometimes plates or pins, the screws that they put in, will actually cause osteomyelitis at the site of where the surgery is done, especially in somebody that's immunocompromised or has peripheral vascular issues, circulation issues. Um, a patient of mine uh, had really fairly severe uncontrolled type 2 diabetes, and with it peripheral vascular issues. Uh, he was constantly on the vigil for foot ulcers and things like that. And and he had chronic non-healing. And he actually was taking um, prednisone for something else, for a lung issue, and I think that he probably had as much cushingoid from the prednisone as he actually had diabetes, but nevertheless, he had high sugar and bad circulation. And he was at a wedding dancing with his wife, uh, kind of moved quickly in a funny direction to avoid bumping into another couple on the dance floor, and he ended up breaking his ankle. He broke his fibula, and it was a non-joining fracture. It was actually awful for him, uh, and uh, they they did surgery on it because it was non-joining. And so after months and months and months of trying to heal this up, they decided that no, in fact, they should open him up and do put a plate in there. And when they did, he ended up with an osteomyelitis post surgery. Again, immunocompromised and poor circulation. The and then because of that, the involucrum, which was very weak, refractured. They had to take the plate out because of the osteomyelitis, and they packed it with antibiotics and they tried to clean it up. Then the infection actually got into his tibia, and he ended up with another osteomyelitis in the distal tibia, and he ended up having to have his leg amputated at the knee because of it. So amputation is really a very common thing for chronic osteomyelitis when it just doesn't respond, when they can't get at it. So it's way better to treat it with antibiotics in the acute stage, not let it get to the chronic stage. Sometimes what they do is surgery, and they literally pack antibiotic putty into the bone, and then they surgically do it. They maybe debride. They try and take away the sequestrum, so that the bone has a chance to heal. But it may go so far as to require amputation. So that's osteomyelitis. Septic arthritis is very related to osteomyelitis. It's an infection, but the infection goes into the joint rather than into the bone itself. Now, this is found. This is found on page 609 in your textbook. So really, this what we're going to talk about here is bacterial arthritis. So it's an acute arthritis, and it's caused by an infection within the joint capsule of an infectious agent, like a bacteria, if it's bacterial arthritis. Um, Usually introduced by direct inoculation, but it can come from blood, or it can spread from adjacent tissues. So say there was an osteomyelitis in the bone and the abscess actually moves into the joint space, it can turn into a septic arthritis from there. If there's an infection in the muscle near the surface, or if even a skin infection can go deep into and end up in the joint. So that's a spread from adjacent tissue. Generally speaking, it's puncture wounds, though. Again, it depends on the immune status, the health of the person infected, what infectious organism it is, and how virulent it is. That kind of thing. So what happens? These people get joint pain because it is painful. There are lots of nerve endings in joints. They get swelling because it's very inflammatory, and loss of motion, lots of use of the joint. Now, 99% of the time, this is monoarticular. If it's spread through the blood, it can be polyarticular, but usually, especially from direct inoculation, it's monoarticular. So the arthritis is there, but there are systemic symptoms. There's fever and malaise, that kind of thing. Now, if it gets bad enough and the joint's anywhere near the surface, pus may drain right out of the joint, maybe back through the original puncture wound. When this happens, it's considered a medical emergency. It can spread and become become septicemia, which is an infection throughout the blood and can spread to other places. It can cause permanent damage to the joint, erosive damage, and cause like a permanent arthritis. But if it's caught early, it responds to antibiotics and can be dealt with quite readily. Oftentimes what they do is they surgically drain it. They put a drainage tube in and try and drain away the pus and the infectious agents in there. People, if it's not caught early, end up with functional limitations. If say this happened in your elbow because you put your elbow down on something and got a puncture wound that went straight into the joint space and into the capsule, then you might have a functional limitation on the use of that joint for the rest of your life, long after the infection is gone. Another infection that we hear about, but the general public doesn't seem to know that much about, is tuberculosis. Everybody knows of TB as a pulmonary disease. It's a disease of lungs. Almost everybody who gets TB has a lung disease. But what they don't realize is that it spreads to extrapulmonary tissues. 10 to 15% of cases of acute TB will spread to other tissues. And 10% of those ones, so really it's kind of like 1 to 2% of TB cases, the tuberculosis will spread into the spine or into bones. And I see I spelled skeletal wrong. I'll correct that. Often, I say spine because it's often found in the lower thoracic and throughout the lumbar spine, which case it's called Pott's disease. That's the old-fashioned name for it, but it's really skeletal TB. Um, it's spread hematologically. It comes through the blood from the original locus in the lungs. Um, but once it gets into a bone, then it spreads contiguously through the tissues uh, where it is. So what'll happen is it'll go from vertebral body through the disc into the adjacent vertebral body, and it can really mess up the whole spine. Can cause horrible neurological conditions, cauda equina syndrome, some vicious sciatica. Nerve root compressions, spinal cord compressions, those sorts of things. Because what happens is that the vertebrae get so uh, eaten out. It's a lytic lesion that you'll get collapses, virtual compression fractures of the vertebral body, and then that in turn leaves less space uh, for the nerves. Um, they treat it. The treatment for this is the same as the treatment for pulmonary tuberculosis, and it's usually treated alongside. People don't get skeletal tuberculosis without pulmonary that I know of. Uh, I guess it's theoretically possible to get it through inoculation, but I think 99% of the time it comes from lungs. Now, the what they can do is, if they catch it early, they can do some surgery. They can do some debridement to try and take away the infected tissue, the infected bone tissue. But if it's in the spine, that's really difficult to do. Um, Oftentimes, what ends up happening is they end up doing laminectomies and decompression surgeries, where they try and open up the space for the cauda equina or the nerve.